we're talking about prolonged field care, austere medicine in regards to walking through the algorithm. So C circulation is so, and this is some of the links that we use here. But the C circulation is so big that we're breaking it down into burn. The next week will be burns, or next month. Next month will be burns, and some aggressive rehydration. For this month, we're just talking about the minor bleeding C circulation option. So these basically what I did. All of these links I got from the CPGs, and I put them onto a spreadsheet so you can download them here. So you can scan that. I'll wait. If you guys want to take a picture of that, or just send me an email if you need the link. That will get you to my Dropbox folder that has a PDF or a spreadsheet of all these CPGs. And this is what we're basing this off. And now I'm using some CPGs from WMS as well because they're that good. But a lot of this is coming just from the JTS. So we're walking through March Pause and Hitman. And for those of you who are using March Pause Hitman, great. For here at the college, we're using CABCD, EFG, H Hitman. And I created that to kind of fill in some of the gaps to make sure that there's not anything dropped. But most importantly is the CABC system that we use ends with H. There's no choice whatsoever. You must roll into prolonged field care. The problem with March Pause, and I've talked to Jamie Reesberg on our podcast about this, is there's a failure to launch PCC. So March Pause, they're like, okay, what do we do now? We're going to do March Pause. Okay, what do we do now? There's March Pause. And I'm trying to push very hard to have March Pause Hitman so they automatically roll over. So this month, we're talking about C circulation. The guidelines are coming from the TCCC. It came out, the latest guidelines are from earlier this year. I highly suggest you guys take a look at that. And this is what TCCC is suggesting that each level has as far as skills. So ASM is all service members. It's 4 hours, 6 hours. Combat Lifesaver, sorry. We always joke about them. Is a 5-day, Combat Lifesaver is a 5-day course. And then Combat Medic or Hospital Corpsman, I think is that what HM is. Combat Life, CMC. And then the CPP, the Combat Paramedic, is what we're focusing on. So these are the skills that we're going to talk about over the next couple of months. C circulation. So I'm using a lot of the prolonged casualty care guidelines, and Sean Keenan says the new ones are coming out in December 2025. You can scan that if you want to kind of follow along. So what I've done is I've went through that guideline with a fine-tooth comb, and I gleaned all of the March assessments, and I've allocated what skills are needed for each level following the Marsh algorithm. So the C circulation, these are and we're going to go through ruck, truck, house, and well, plane is not always used now. So we're going to focus on ruck, truck, house. So the Combat Lifesaver circulation assessment is exactly the same as the CMC circulation assessment and the Combat Paramedic assessment. And these are the skills for the ruck phase. Now, who can tell me what ruck phase is?
Is that just primary assessment all the way through to getting them to a secondary unit, or are we just basing off of the amount of equipment that you have?
So it's the amount of equipment. So all the kit that you can carry in your ruck or on your own harness is considered ruck phase. So when you run out of that, so your sked or your talon stretcher might not be in your ruck, or maybe you carry it. So it depends on what you carry in your ruck. So Rhod, what you have a lot of ruck calls, don't you? So what are you carrying in your ruck kit?
Well, what I've actually found over the years is my ruck kit has just got smaller and smaller and smaller. So sort of back in the day, it was like everything you could cram into every pocket going and every gadget that you possibly can. And I think it comes down to an experience thing of, you know, can I do more with less safely? Yeah. I mean, particularly if you're, you know, some of the environments where you're not only carrying your med kit, but you've got operational kit to carry, and you've got to operate on foot, etc. You really want to minimize that amount of med kit. And that'll even go for the truck when we move on to that next slide. So, yeah, I would go as minimal as is safe to do so for the environment that you're operating in.
Well, working on the ambulance as a paramedic, our ruck kit was huge, right? So there was a trauma ruck or a bag you threw over your shoulder. There was a cardiac. You had your DFib Life Pack 15 or 25, whatever they have them now. And then your oxygen and maybe a separate drug. When we're doing on HEMS, it's always a separate drug. So yeah, the ruck kit for me was huge. Mason, you had a point?
Yeah, I was just going to say, I kind of agree with Rhody. You know, as you get more experience, you learn that a lot of the things that you start off with special equipment for, you can use some basic common supplies. And not only does it mean you have less, but if you have, you know, if instead of having 10 specialized types of bandages, you learn how to use one, you know, basic gauze and modify it to do the things you need, that means you can have more of it and can be more versatile for the different situations. So I think it's, you know, it's, from my perspective, it's best to learn to do as many things with as few supplies as possible for a capacity thing, but also for a redundancy thing. Because if you need, you know, a gauze for each type of wound, and you have two of the same type of wound, you only have one gauze that fits that wound, it's going to be a problem. But if you have 10 gauze that can be used on any wound, I'm just giving a simple example, you know, it makes you more flexible in what you can deal with if you're using a more limited set of basic items that you can stock more each of.
Anyone else?
So I guess just speaking from the like wilderness firefighter perspective, you have kind of two ruck phases where you've got your ruck that you're going to be traveling with, but then the potential that you're going to drop down to the nursing care stuff. And the second line of a lot of my meds that would be in my primary ruck.
Good. Some of our missions in SF, we would have our ruck, and then we would have a second ruck stationed with the aviation platform. So if we got into the situation where we stabilized a casualty, all we had was a ruck. There was no truck, there was no house, there's no plane, because we were just in an ops where that was the case. So it went straight ruck to, I guess, plane. So, but the heli would come in, land, and then they knew to bring another ruck to replace the ruck that we just went through. So that was something to pre-plan. So, and you can do that with your own truck. So in your truck, you have your ruck, but you should have another, we call it a speedball, another bag with all of the quick to be depleted items. Macy said rolled gauze, or, you know, tourniquets, or quick clot, some sort of hemostatics. What is it you're going to burn through quickly, and you can have that to quickly resupply.
I feel like everything that's been said about minimizing things also has to take into consideration your patient population, because you can very well minimize everything if all you have is 27-year-old males, you know, 6 of them. You can really standardize all of your equipment versus you know, if you're expecting to see a neonate as well as a 107-year-old patient. So yeah.
You're right. We had it easy, didn't we, in the military? And now that I'm working in the civilian side, yeah, I got to look at hypertensive emergencies, and as well as obstetrics or pediatric issues. Good.
But even when you have multiple populations, I think, you know, there's an art to it too, right? I mean, for example, I don't know why you need 5 different types of NSAIDs. I mean, for the most part, if you believe in class effect, you pick one NSAID that has the lowest side effect profile and you stock it, right? Like if I have naproxen. I don't also need ibuprofen and meloxicam and all these other things, right? So I'm not saying have nothing. I'm just saying think carefully about what can be used multi-purpose and get the one that's the easiest to use that can be stocked up on.
No, I think that's an absolutely perfectly valid point, Mason. And we had a very similar discussion on one of these chats a couple of months back around antibiotics as well. Because you can carry the world load of different antibiotics, but at the end of the day, I think when we talked it through, we worked out that there were was it 5 Aebhric that we decided we could get away with?
You can do pretty much everything you need with 5. Yeah. So that's a good point with the NSAID. So paracetamol is mandatory, but paracetamol is going to work with an NSAID. So what one NSAID would you have in your RUC kit?
So I just carry meloxicam and Voltaren.
Anyone else?
I mean, this is not my area of expertise, but from my perspective, I think naproxen has, a good weight to strength ratio, and it's probably one of the softer ones on the stomach with a long duration. So I think naproxen's a good option. But
Is that the one that had the hypertensive problems for us old guys?
I think that's a class effect too. I think that's any NSAID can have that problem.
Yeah, everyone. Good.
I don't know what you guys think about in terms of determining your size or your pack amount is really determining what level of care you're trying to bring, because I feel like there's definitely some arguments to, if you're trying to bring as little stuff as possible, to only guaranteeing BLS level care versus some ALS capabilities. So how do you guys make that decision process as to what your level of care you're trying to bring to?
It's always going to be task specific, Tango. So you carry out your medical intelligence assessment based on your task, your population at risk, and then you're going to have to work out your kit list, etc., depending on what your hazard exposure level is. Really, there isn't a textbook answer on this one. It is a little bit experience, toe in the water as you go. And certainly, as well as I was saying a few minutes ago, you start big and then you whittle it down, but there is a point at which it's not safe to go any smaller.
Makes sense.
Yeah, the thing about
also then defining where the next layer of supply is going to come from, how long that's going to be. It's going to force you to decide if you really need to have something in the first 30 minutes or in the first couple of hours, or if you can wait for it to show up.
Yeah, and the thing that got me really thinking about this is I spent a month up in a military base at the North Pole, and there was a very real chance that we could be like a week or two out from resupply if weather was bad. So, it's about having fewer things, but having enough of them to last you until you can get resupply, which some places can be, a week or two, right? So probably better to have a bunch of one thing that you can keep going rather than 18 different antibiotics that you only have one day each of, right? Depending on your situation.
That's a great point.
So looking at the circulation assessment with the RUC, anything you guys would add or anything you want to mention about this list? You guys have a lot of experience. What are we missing with circulation assessment in the RUC? I carry some stuff that's not on the list. What do you guys carry? Rocky, you have a question?
Am I missing that?
No, sir. I was just responding to the previous question of whether the screen is small.
Oh,
yeah,
got
go
it.
ahead.
Fair enough.
Sorry.
Yep. So any guesses on what equipment that I carry that's not on this list is very good for circulation assessment?
I don't know if you consider this, but tranexamic acid.
For assessment?
Oh no, okay. That's
Yeah.
I see what Nikki's there too. So I don't know if you meant treatment too.
Yeah. No, we're
Yeah,
definitely going to talk about that. But good. POCUS, ultrasound. How would I use ultrasound to do my circulation assessment?
IVC collapsibility.
Good. Is that a RUC thing or is that a truck thing?
Personally, I would say truck.
Yeah. So I definitely am going to carry it, but that's let's do some easy ones. I'm a big focus guy. I'm not saying that's not you're not going to do that, but what's something I can put on this guy that'll immediately tell me a lot about their circulation? There you go, SpO2
with a good waveform reading.
Yeah, there you go. So I want to see that waveform, how wide it is, how narrow it is, how high it is. So this and good cap refill. This is why we go with CPRO. Cap refill, pulse, respiratory, and oximetry. And you do all you need is SpO2 monitor, and you have a very good cardiovascular assessment on this guy. So PCCC does not mention that until later, but I would bring it up here. Good. They do talk about check pulses and skin color. Good. Extremities. So you can test shunting. If your casualty is cold at the feet and the hands, they're starting to shunt. Good. So moving on to the next. There we go. So this is circulation assessment, ROC at the next level. So not the combat lifesaver, but the combat medic. Anything different or anything that you would add to the circulation assessment here? And Mason, this is where we're starting to see treatment. So TXA is there as well.
I'm sorry, am I missing what form of documentation is expected in this? Is it paper? Is it digital? Are they mentioning
Paper.
that?
Yeah. So they generally, well, to be fair, the tablet assessments are getting really good. So we use something called Medic Tool in our college. There is BatDoc, I think, in the US, that they don't have any paper anymore. It's all just a little tablets that's right on their chest. But generally, this was when they created this in 2021 was just for the TCCC card. Mason, you said urine output for circulation. I completely agree that if they're doing during urine output of 30 to 50 an hour, I'm happy. Alfredo?
Yeah, I've got regarding the goals of resuscitation, the blood pressure, better a systolic of above 90 and best between 100 and 110. It all depends of the patient's injury, because depending and how long it will be with the patient, you always think about the permissive hypotension. If the patient is bleeding, have internal bleed, I may not follow these. I'll keep the blood pressure low, and hopefully with the XA we'll create a clot somewhere to stop the bleed.
Good. So hypotensive resus. What are your thoughts on hypotensive resus?
It depends how long going to be with the patient, right? If you have a low blood pressure, a low MAP, it means that going to reduce cerebral perfusion, but they're going to give some time for the body to create a clot. However, I won't be able to keep a low MAP for a long period of time. So eventually I'm going to need to raise it eventually. But initially, at the first minutes, half an hour, depending how the patient is in the resuscitation mode, probably keep the blood pressure a little bit low until see some improvement per se.
So you mentioned time. What's the magic number? How long can you do this for?
Oh. Ideally 10 minutes, but depends on the patient, depends on the injury, depends what I'm concerned about. If he's medical, I think about the AAA, and if I have a high index of suspicion that they should go to AAA, I probably quite happy with the blood pressure systolic of 90. Trauma to the torso, the same. And see slowly, because if I increase it, I'm going to make it worse.
Mason, you had something?
Yeah, I was gonna say, I think also it's not just about the pressure, it's about the perfusion. So like someone who's got a pressure of 90 but is on like norepinephrine and has like super cold extremities. I'm a lot more worried about than someone who's got a pressure of 90 on no vasopressors, who's gotten some fentanyl and their extremities are warm and they're having good urine output. So I think it really, like, you look at the end organ perfusion rather than just the pressure, and that's what matters. And I think you can resuscitate and then actually give them some opiates to reduce some of that catecholamine tone and allow increased perfusion. Even though it'll technically drop their pressure, it's actually improving their overall state.
So what's the maximum we can do hypotensive resus? William? Yeah, William, go ahead. You got a question.
Sorry about that. I was just with regard to this hypertensive resuscitation. From what I've read, it is only really indicated for those non-compressible injuries. So that of like abdominal trauma or something like that, where you cannot compress that. And by keeping the systolic in and around, or the map around 60 or something along those lines, you're allowing that clot to build up. Whereas if you had someone that had an amputation, for instance, there's no, and that was a sole injury, there's no real need to practice hypertensive resuscitation for that, because you have compressed that that bleed. Am I wrong?
No, that makes perfect sense, because if you have a tourniquet on, you no longer have appendage that's going to bleed out, and therefore you can raise the blood pressure up to, well, urine output of 50. So yeah, you're absolutely right. If you have a leak somewhere, you want to do a hypotensive resus for up to an hour max to give that clot, and you're giving TXA, so that clot is, instead of being this big, maybe it's this big, and that will increase outcomes and help with your patients to reduce bleeding. Anyone else?
I have a quick question. So, this isn't necessarily a good topic for the ruck, but I just wanted to put it out there. So, there's an argument I heard recently, which I find interesting, but I don't know how much validity. There's the idea that, let's say our patient is exsanguinated, they've lost a bunch of red blood cells. We're seeing an SpO2 in the hundreds, and but we're going to give oxygen anyway, because the idea is, even though all of those red blood cells are saturated, they still don't have enough for end cells to be grabbing enough O2. And I don't really know how much logic that has. I mean, it makes sense to an extent, because either way, the SpO2 would be measuring 100%, regardless of how much hemoglobin there is. So I get that. And on the side note, sort of the reason why I've thought of that was because if we do have a compressible hemorrhage, we've stopped that bleed. Let's say they've got a really low amount of blood in them. We fill them up with pasta water. Are we going to want to try and give excess O2 in that situation? This is it's not for this situation, obviously, just in a ruck. But what are our thoughts on that?
So my understanding, and I'm only a paramedic, but oxygen is a drug that you give it when it's indicated for that. And then on top of that, we're in a situation where how much oxygen do we have? We have a D cylinder. What is that? 24 minutes. I don't know. I don't know the pathophysiology of someone who has 100 SpO2 that still has an oxygen delivery that's not enough. Anyone with a better pathophysiology of the difference between DO2 and oxygen saturation in the pipes?
Yeah, I mean, I forget the exact number, but I think it's something like 2.5 or 3 atmospheres. If you put someone in a hyperbaric chamber, they can survive with like almost no hemoglobin. But at sea level, the pressure is not enough. You still can't dissolve enough oxygen in the blood to replace the need for hemoglobin. So I mean, it's a cool idea, but unless you have a chamber, which I mean, probably you have blood at that point, is not that helpful.
Good.
That was my thinking as well. Okay, thank you. Cool.
All right. So looking through the circulation assessment and treatment of this casualty, in the ruck phase, where it's a point of care, point of injury, we are stopping a bleeding. We're doing a assessment of the cardiovascular system. So we talked about the CPRO getting BP at 90 or higher, getting the MAP at 65, which is very important to calculate the MAP. So when I teach the eye care, I'm beasting our students calculate the MAP all the time to make sure that they focus on the pressure within the system and not just the systolic. What else do we have here? Shock treatment, looking for alternative causes of shock, treat with crystalloids. So yeah, down there in the bottom, I was talking about crystalloids. What color of fluid did they lose?
Red,
What color of fluid do they need?
also red.
There you go. So I think at the CMC level, according to TCCC, they're still not pushing outside of the Ranger Regiment. They're not pushing red fluid forward, but that needs to happen. And here on the second to the bottom, a urine output of 0.5 mils per kilo per hour should be tattooed somewhere on you guys. Just you look at MAP, look at urine output. Between those two, that you have a really good understanding of cardiovascular system. So we stabilized them. We got them into a stretcher or gurney if we're paramedic, get them back to the ambulance or get them back to our truck with Rhod. It's probably an SUV. So what type of kit do you have available for circulation assessment in your truck?
I mean, I wonder if you could potentially argue that, you know, in addition to the ultrasound, probably the truck is where the blood pressure actually matters. If you don't have, you know, a whole amount of blood or anything to give in the field, I don't know what the point of measuring a blood pressure is, but maybe I'm wrong. That's kind of my thought is.
It's a good point. Possibly ruck phase for a burn injury where you would give plasma, but before the blood. That's a good point, though. Rhod?
Mason, oh, sorry.
No, sorry, Tango. I was just going to concur with Mason. Actually, for me, for the ruck phase, I mean, essentially, certainly in my operating environment, if they got a radial, I'm kind of happy, and at that stage of the game, I'm not going to be starting to bang up bags of IV or whatever. That really is going to come at the truck phase of the whole methodology.
Are you guys deferring any medications like analgesia till the truck?
Yes.
There's some good research on aggressive pain management reduces PTSD. So when I was working in ER 24 in Johannesburg, man, ketamine for everything. I am ketamine in the arm, and it worked really well because I've had ketamine myself, and it's about 120 seconds to start working, and you just can't overdose with 50 mils. So I've been in environments where it's a bit more aggressive to do pain management forward. Any other thoughts?
We used to use the old fentanyl lollipops quite a lot in Afghan. You know, so if they've got a reasonable LOC in the field anyway, you know, post POI, give them a fentanyl lollipop to suck on. And, you know, the great thing with that is, again, you're not going to OD on it. And we used to do the old tape it to the thumb, get in the mouth jobby. That used to work pretty good, actually.
The one thing I would say, you know, again, I don't really work in the field. I mainly work in the hospital and things like that. But someone who's a severe trauma and is on the brink of death, the only thing that may be keeping them alive is their catecholamine and their, you know, vascular tone. So, I mean, obviously, I want to treat pain as soon as possible. But if you don't have the ability to resuscitate a patient, I'd be very hesitant to give significant analgesia to you know, severe trauma until you've got them resuscitated, because it may be that you give them ketamine or fentanyl and that's enough to like relax their vascular tone, and then they bleed out and they die. So like they're like, I think, you know, a lot of times when you intubate and you do RSI, that's why people die, because you've lost all their vascular tone. So the philosophy is like, you know, resuscitate before you intubate. You should probably resuscitate before you give significant doses of analgesia too. I mean, I know it sounds mean, but I think there's something to that.
Good. Alfredo?
I just absolutely agree with what Mason just said. Of course, ethically, gotta let the patient suffer, which isn't great. About opioids, I'm a bit concerned because there are some patients are opioid naive and the blood pressure may drop. Ketamine is a great drug, but I rather give her a higher dose if I can, because the patient may start hallucinating and will lose it. But on the other hand, as soon as I give him ketamine, I no longer have contact with the patient. I'm going to lose the patient completely. So I know I need to carry him with me. With opioids, the good thing with the lollipop is, okay, if the blood pressure may drop a little bit, but the patient will stay with me, answer my questions. For the ketamine, it's gone. They start talking rubbish and start behaving in a way that I don't want to. That's the reason why normally I tend to increase the dose a little bit to knock them out per se.
And the other thing about ketamine to consider is, like, a lot of the time in healthy people, we consider ketamine to be hemodynamically stable, but that's because it does have some vasoplegia, but then also counteracts that with encouraging the release of adrenaline endogenously. So if you've already released all your adrenaline, then there's actually some decent evidence that ketamine is not hemodynamically stable in someone who's in severe shock. And it's kind of somewhat similar to other things in that case, because if it has no, adrenaline left to counteract the other effects, and it becomes more hypotensive causing than it was in a healthy patient.
Good. So circulation assessment with truck. This is Nicole, you mentioned POCUS. Good. What else? So we're doing an EFAST here just to assess if there's a massive hemorrhage within the body. We can do IVC. So I think Tanguy mentioned that to see collapsibility. And initiate hypothermia prevention measures. I'm seeing hypothermia being done a bit earlier than that. I'm pretty happy with how we teach it at college. You really do need to wrap that casualty early.
It's one of my bugbears, mate. We need to be initiating it. It should be part of them in the March protocol, in my humble opinion. Good.
Alfredo.
Yes, I only have one thing to say about hypothermia. That's something that I see over and over, especially in the ambulance service, the civilian ambulance service. Okay, it's cold outside, right? It's winter, and we get to the patient and we cover him with blankets or whatever you've got, and then start giving cold fluids. So it's a contrast. So I'm a big fan of fluid warmers, or at least have a warm pack inside of the ambulance when the fluids are at least a reasonable temperature to be administered in case of need. Because it's so common, people giving fluids at normal temperature. The current temperature will be about 5 degrees or so. So we're warming it up in one hand, but holding it down to the opposite. So I don't think it's appropriate. But it's just me.
Yeah, good. All right, let's move on to house. So this is a clinic, or this is the ER department, depending on what you're doing. Rhod, I'm guessing you have your clinic. So what kind of circulation would you be doing at your clinic site?
The main site clinic is pretty well set up, to be fair. I mean, we've got a 2-bed ward plus a resus bay, which we were actually utilising last night at 1:30 this morning, actually, which is why I'm a little bit vacant. At the satellite clinics, then it's very minimal. But actually, at our main clinic, yeah, we're pretty good, and we're probably better than the local hospital at Chamchamal. So we would tend to hold people here, stabilise, and then arrange an onward movement to either Suleimania or Erbil if necessary.
So you have remote clinics where you'll have somebody stabilized, put them in a truck, go to this other clinic where you're not, and then put them in another truck and then bring them to you.
Correct.
Fair enough. Anyone else?
Is that sentence about vasopressors assuming hypovolemic shock, or is that post?
So I got this straight off the CPG. So let's talk about that. And Alfredo, then we'll get to your questions. Vasopressors. So are we going to rob Peter to pay Paul?
Depends on if you're American or European. The Americans say pretty much no, and the Europeans say you can add a little bit for a balanced trauma resuscitation.
That
So
was
I-
actually
Yeah, go ahead, Alfredo.
that was actually the question I was about to ask. Which would be the best or the vasopressor that CoROM supposed to support it based on all the guidelines? I already work with 4, but that is just me. But I just want to hear what you guys have to say about what would be the best, cost-effective as well vasopressor to give it.
Well, I'm going to pass that to Mason.
In terms of which is the most cost-effective vasopressor, you're asking?
No, it's best. Again, I work with 4. Will be norepi for me is the best, but again, it's better to have a syringe driver, so probably won't be the best way to do it. Epinephrine probably is the easiest one, and there are 2 others. Dopamine probably drops the same thing, although we can run it in a bag. And phenylephrine, and there are others. I just want to hear you saying what will be the best for trauma or hypovolemic shock.
I mean, I think it depends on the situation, right? I mean, personally, I generally work with 3. I use norepi, epi, and vasopressin, depending on what effect you want to achieve. And I don't think you can say in general one is the best. Like if someone's got poor peripheral tone for whatever reason, then norepinephrine is a reasonable one. If they've got a bleed in the intra-abdominal region, then vasopressin could be good because it can kind of clamp down on the splanchnic arteries. If someone's got spinal shock or neurogenic shock, then you probably want to add in a little bit of epinephrine, to bring the heart rate up. So I think it's kind of a more holistic look and see what you're looking to achieve, making sure at all times that you're ensuring you focus on perfusion rather than the number. I think that's really the big thing, is perfusing the areas you want rather than worrying about the number that shows up on the blood pressure monitor. Like I said earlier, if you have a patient who is awake and talking and warm in the extremities with a systolic of 90, I'm less worried about that than a person who's got a systolic of 100 but is unconscious and their extremities are ice cold and you can't palpate anything other than a carotid. So yeah, I think it really depends on the situation. There's not one best. I would say dopamine is probably usually the wrong answer, and phenylephrine is also probably usually the wrong answer because dopamine is pretty unpredictable with some weird side effects, and then phenylephrine is really just, in my opinion, unless it's counteracting the effects of anesthesia, phenylephrine just gives you peripheral squeeze only with no improved forward flow, so it makes your number look better, but doesn't actually improve your perfusion to anything in general.
Thank you. I totally agree with what you just said. I personally I use a phenylephrine a few times. Didn't reach my target, and dopamine, as you mentioned, a lot of side effects, and it's dose dependent, and sometimes the patient don't match what the dose that we want. Norepi is for me the go-to, but again for remote areas, we probably need to have norepi or epi. I just want to hear what you're saying, but again, both will be fine. Thank you.
So Nicole, I saw you said something. If you can pop in and make your comment, it'd be helpful.
Hi there, sorry. Can you hear me?
Yep.
Okay. So yeah, just in choosing like vasopressors, like in time sensitive situations, I've often used phenylephrine just to kind of give me 5 minutes to start an infusion. But those infusions are really based on that patient. Like, what do they need? Do they need perfusion, contractility? Is that going to affect their cardiac demand? Can their heart actually sustain that? So everything is based on, do they need more alpha or beta, or do they need vasopressin to affect the V1, V2 receptors. So it can really, really be a factor of titrating that. So knowing what receptors need to be triggered based on that patient specifically. So I think just carrying like 3 or 4 pressors is absolutely reasonable. Then you can actually even use 1 or 2 to balance that out. And I think that's quite reasonable. We usually carry about 4 or 5, but I mean, we're specific to critical care in long haul transport. So we need a little bit more variety, but I think it's just it's really patient based. But in time sensitive, we often use phenylephrine, very rarely epinephrine, because our critical patients are usually in a heart failure situation, so their hearts just will pooch out. But yeah, that was all I had to say.
Good. So speaking from the austere environment or LMIC countries, the only thing that they can get readily and cheaply is epi. So we have to be ready to do 1 of the 3 doses of epi from a vial, and that if that's the only bullet you have in your weapon system, then you got to do the best you can with it. Let's take a look at. All right, so this is the last of the assessment side of things. Now, wanted to go through some of the skills that are in the PFC guidelines for circulation and pelvic binders. So, good, better, best. Good, obviously, is going to be anything that will immobilize the pelvis. So here we have the improvised pelvic binder with the pants, and I'm teaching this next week at the CMC. But we prefer to have better and best. So, how many of you guys carry best? Which I'm guessing is going to be one of the pelvic binders. So Sam Sling or T-Pod. How many of you guys carry that in your rock kit? Yeah, go ahead.
Yeah, I have a Sam, one of the that I could double it.
You're breaking up a bit, Trent.
Yeah, sorry, it's a yeah, I have a Sam Junctions one that doubles as well.
Good. So it does everything.
Yeah, it does everything half well.
Good. Anyone else?
We have it in the truck, but I just wanted to bring up a point I found out a couple of weeks ago. There's really no point in having 2 sizes in those things. Just have the small one, because it feels really bad when you max out that large one and it's not holding tight enough. I really don't see the point in them making even 2 sizes.
Yeah, fair enough. How many of you guys are comfortable doing the improvised pelvic binder with cutting up pants?
Yeah, I've had a play with this. I quite like Mike Schertz's demo on it. Really
Yep.
good and straightforward. I've not done it on a live casualty. I do a Sam Splint tubey grip.
Oh, nice. Yep, that's always good because that sand splint can be used for anything.
Yeah.
Yeah.
So I have that pre-prep with the tubey grip on it anyway, and it's a multitude of uses anyway. So
good.
Yeah.
Good. Wound exposure and wound packing. Yeah. So, and then we'll talk to tourniquet, but how many of you guys would wound pack, or would you just put the tourniquet on and take them into the bright lights and cold steel?
I mean, I think it depends on your environment and how many wounds they have. If you have someone who's like in a non-combat environment and they have like 1 puncture wound, then you can pack it. But if someone's been shot in the gun, the bullet's just still flying, then probably just throw a tourniquet on and get out of there.
Fair enough. I'm seeing some other comments. Adam, you said something. Diana, just pop in and if you guys are okay, say that out loud so you can hear you.
Sure. So I just came of wilderness training and would discussing it was some controversial statement saying that the pelvic binders were rather ineffective if you wanted to both, work with bleeding control and stabilize pelvic injuries, that it only works for one type of injury, and they rather prefer you to improvise with a sheet or cut down trousers. So I want to know what your opinion is about it, because I really don't. I have no idea.
Guessing 8 to 10 studies showing that pelvic binders are good. Rhod?
Yeah, it's a bit like the old C collar, isn't it? I think a lot of the issues that have come up with commercial pelvic binders is just that they're being incorrectly applied.
Yep, they're not.
I think part of what Di's saying, and Diana, please correct me if I'm wrong in my interpretation. I think with the wilderness side of it, that's probably going along more with my mindset and how I've been talking of do a bit of improv and you have one piece of kit that covers a lot of areas. But once I get to my truck, I've got SAM pelvic binders, and we will convert from the improvised to the commercial device as appropriate.
That's what I figured out myself. But it was controversial because this person was adamant on how commercial devices could only address a certain type of injury, and I couldn't really wrap my head around it. So thank you.
I'm going to nip that one in the bud before Mason comes on. There are tons of published research, good research, showing that pelvic binders work. So he was wrong.
Thank
Mason?
you.
Mason?
So I'm going to agree with both of you guys. Actually, I think Aebhric, there's great evidence that pelvic binders work in open book fractures. What I'll say from the trauma perspective in a trauma hospital is at least 90% of the pelvic bleeds we see are not open book pelvic fractures. So like a lot of them are just, well, maybe it's because we're seeing a lot of old people who get in car crashes, like lower energy, that they have like little breaks in like their pelvic rim, not a full open book fracture, in which case, the pelvis is already still intact, but it's bleeding on the inside. So if it's the right injury, a pelvic binder works perfectly, but we have lots of pelvic injuries that the binder was not intended for and it won't work on. So I think maybe that's where they're coming from there, and like they're kind of conflating with it not working when you're applying it for the wrong thing, right? If you put a pelvic binder on because someone broke their the inferior pubic rami and there's a little venous bleed going on the inside, that's not going to do anything because the pelvis is still stable. But an unstable pelvis fracture is certainly going to help in those cases.
Alfredo?
I'm sorry, wrong, but again, I agree with Mason. It's exactly that. I think it's about 7 types of pelvic fractures, and the open book is the one we use pelvic binder for. The rest, theoretically, the iliacs will be intact.
William?
Aebhric, with regard to these several different types of pelvic fractures and so on and so forth, I mean, I'm a paramedic, I'm in the field. Someone's got a mechanism of injury suggestive that they might need a pelvic injury. They try to, say for instance, this person is able to communicate and they try to lift their right leg up and it's painful. That's now kind of alarm bells ringing. Sure, if they are a bit hypertensive, then that's something further. But regarding, all of these other different types of pelvic injuries and so on and so forth, in the field, I'm not going to know that if I'm being brutally honest. So whilst we're here, what would be your main indications for applying a pelvic binder in the field?
Mason?
Yeah, I mean, I think it's really the clinical exam, right? If you try to, compress the pelvis and you feel give, then apply it because that might be an open book. But someone who moves their leg and it hurts is more, at least again in my, civilian experience, is more likely going to be like a hip fracture, in which case pelvic binder won't help. So it's really, do you feel the give way when you try to compress the pelvis, and if so, you put the binder on. But I wouldn't do it. I mean, you're not going to necessarily cause harm, but it's not going to be helpful most of the time if they just have pain in the pelvis. It has to be that it's an open book, that it's unstable when you try to compress the pelvis. I think you guys teach that in the paramedic course, right, Aebhric?
Yep.
Scene.
And the feet. So the feet tied together is the number one thing. You tie the feet, you mobilize the feet, and then they won't move, even despite whatever type of pelvic fracture they have there. Good.
I really don't see any downside with just doing a sheet papoose for everything, because if it is a humeral head fracture, then it's still going to help immobilize. It's not going to do much about the bleeding, but it's just helping immobilize. And then if it is a pelvic issue, then you can create enough tension. I mean, it's not the level of tension, but I feel like it's a lot of a safer bet. Will, if you have questions as to what it is, you're improved. You've got a lot safer options with your papoose than you do with your pelvic binder.
I mean, I think anything applying pressure on the greater trochanter, if you have like an intertrochanteric hip fracture, is going to be super uncomfortable and may make the fracture worse. So that is the one countervailing point. You probably don't want to squeeze someone's trochanters together if they fracture their trochanter.
Good. Moving on, cognizant of the time here. Tourniquet conversion. So when do we convert a tourniquet? If you have a casualty for long periods of times, you're just not getting him to the A&E department. How soon, or what do you do with this tourniquet?
I think we need to know if the bleed actually stopped and if it's arterial. But if we provide care under fire and the patient got shot, we're going to put a tourniquet and evacuate him. But as soon as you have time, we need to reassess and see actually what kind of damage he's got. And if it's not arterial, we can pack it. Or if it is, it will be a little more difficult to stop the bleed.
Let's make this easy. This is not combat. This is a cougar attack in the wilderness or something like that. How long can you keep a tourniquet on? Trent?
Yeah, I would start to think about transitioning it at around 30 minutes. And then, doing it anywhere between, after 2 hours to maybe 6 hours. I would want to have the monitors and other drugs and everything if I needed it.
Good. 2 hours is kind of the magic number. You need to think about it before then. Any other comments?
Maybe just to, fact check myself on, would you consider doing it before 30 minutes? I've kind of gone with 30 minutes because it seems to be that kind of sweet spot for clotting factors. And so if I had no reason to, I would not transition it earlier than 30 minutes unless there was like there was like a severe illicit pain response that I couldn't manage or something like that.
So let's assume that 2 grams of TXA gets on 5 minutes in past injury. How long do you wait to let that TXA work?
Yeah, I'm going to say 30 minutes.
Anyone else?
I would say that, because normally you say that as early as possible you convert the tourniquet, and the tourniquet is not a device for primarily, like if you have a strong bleeding at the leg, that you go to if you have enough resources. It's more the tool that you use if you have a lack of resources or time. And so if you can do a pressure bandage, for example, that's a better way to do it, even if you have a tourniquet. So I would say, like, go for it as quickly as possible.
But we definitely need to give the TXA time to work with that. Nicole, you're saying TXA is 5 to 15 minutes with a half-life of 2 hours? Alfredo?
I have this issue with TXA about the time, actually, what time it takes for it to work. Because a lot of people and a lot of studies suggesting giving TXA IM, for instance, and if it's okay if the patient just got injured and still is in compensated shocks, so the limbs are still perfused. But if we get there, especially is in shock, so vasoconstriction, if you give him the TXA through the muscle, probably it won't be absorbed as well if he was well perfused. So I have a few issues about this because I don't exactly know how long it takes because we cannot physically see the clot forming.
Yeah, assuming that you've stopped the bleed and you've done this IV and not IM, the TCCC committee is still discussing IM, but I think they're going to approve it. But we're assuming that you're given this IV and you need to give it time to work. Nicole mentioned 15 minutes. Trent, you mentioned half an hour. I'm okay with that. Anything up to 2 hours, sooner the better. So there's a mnemonic I created called Stable, Able, Fully, Early, to just make sure that you have all the bullet points in place before you release that tourniquet. So you've packed it, you can still visualize it. They're not in shock, and bleeding's controlled. And so hopefully this mnemonic will be easy to remember.
I love that, Aebhric. Just a clarifying question. When you say fully, can we not, if we've got a little bit of oozing, can we not just pack that?
So no, this is fully controlled. Yeah, no oozing, fully controlled.
Okay.
So
Okay.
hemostatic, and that might be me putting half my body weight on that bleed. That's controlled.
Okay, so that's what I meant. Yeah, so
Yep.
if we're loosening and we have some, we can control it by other means, is what I meant.
Yep, absolutely.
Instead
Yeah.
of just retightening.
Yep.
Okay.
Yeah, good question. All right, we are at 1 hour now. So in the TCCC, you're talking about wound packing and pressure bandages of 3 minutes. I'm an advocate of 5. Even though the packet says 3 minutes, do 5 minutes. We did some tests on live tissue when I was teaching for Dr. Hagman for about 7 years, and it's just, I don't know why we never published it. But yeah, 5 minutes is much better for hemostatics. And yeah, that's so next month will be more of C circulation. We'll talk about burn, shock, and blood options. And according to TCCC, Prolonged Field Care CPGs. But before I sign off, I wanted to ask you guys, what is this format working for you? Is this level working for you to discuss these topics? Happy enough? All right. So, yeah, thanks for spending an hour with us. Bill Vashis will be back next time, along with myself and Rhod. I think it'll be kind of the three of us running this. And if you have any questions, my email is always open door. So aok@corom.edu.mt. If you want to email Rhod, it's r.jordan@corom.edu.mt. And yeah, thanks for spending a lovely hour on Saturday with us. And go out and do great things. Make the community a better place. We'll see you next month.